in plain terms, trying to understand the three groups of medication that you have described. Surprisingly, you said that a group of medication which usually alert people, make them more alert, that is what we call as a stimulant medication. You say in spite of the kid being hyperactive, we still use a group of medication called which make children even more alert. But surprisingly, in those children with ADHD, this group of medication will help to reduce their hyperactivity and inattentivity and impulsivity. So this group of medication is called the first group of medication, which is the stimulant group. You have described to us another type of a stimulant group which acts through a different chemical than the chemical which is useful in the first group. But again, this second group is also a stimulant type of medication. And then there is a non-stimulant type of medication which is also helpful, where we find that children who are being given stimulant kind of a medication are having lot of anxiety problems. They are not able to tolerate those things, or they are not responding those two groups of medication, can have this third group of medication. So overall we have three groups of medication which act through different ways to reduce the component of ADHD. The problem of ADHD may be a lifelong problem, though in some children it may not be. So children might have to use the medication for quite a long time. But you have also mentioned that as they grow, usually children will need increasing amounts of medication, but during the school holidays we can try and see if a reduced dose of medication is helpful, and then see if we can reduce down the medication. So there is a way in which we can titrate or adjust the medication dose to suit the children's needs, each children's individual needs exactly. So this is what you have described. Okay.
And Raghu, just I wanted to mention that I think with these medications, I think these three classes of medications, the stimulants is the first line. The atomoxetine or the alpha agonist that we talk about, the other two classes, we can use, I think, either of them as a second line. And sometimes in some population, they even use the atomoxetine. In the US, they call it Strattera as the brand name for it. Sometimes it has been used, I think, but it can be used technically first line too. But stimulant medications by far have the best evidence.
So the first group of medicine which act on a chemical called as dopamine, and which act usually in people by alerting them more, act in an opposite way in children with ADHD, and thereby help them reduce the attention problems, reduce the hyperkinetic problems, and reduce the impulsivity problems. This is what you said.
Yeah.
I think for the moment, I think that should be enough in terms of treatment, Venkat. Now, is there any other thing with regards to ADHD that we have to take care of in terms of children? Particularly, let us now go back to our mother country. Let us not consider USA or UK. Let us go back to Indian scenario. Let us think about the situation in Mandal headquarters or district headquarters or taluk headquarters, etc. What is the single most clinical resource you would want the parents of these children to go to? Is it a neurologist? Is it a pediatrician? Is it a psychiatrist? Who should they go to? Because what I see is that in our Indian scenario, or for the case scenario in Pakistan, Bangladesh, Sri Lanka, Nepal, etc., where 75% of our healthcare expenditure is out-of-pocket expenditure, I would want to reduce the amount of money and effort spent by the parents in getting the correct diagnosis and correct treatment. Who would you recommend as the most appropriate person to go to for children starting from 3 years of age to up to, let us say, 12 years of age? Who do you want them to go to first, and who do you think is most appropriately placed to make a diagnosis of ADHD?
A difficult question, Raghu. The reason being, I think most mandal headquarters, they do not have psychiatrists. But often, I think they do have, 4 or 5 pediatricians, at least from AP that I come from. At least you'll find, a small group of pediatricians working together. So probably, I think they'll be the first line. I think if at all, if you want them to taken care of, if you want, I think accessibility-wise, that is going to be the most ideal, because there are going to be a lot of pediatricians there. Both pediatricians and psychiatrists with the appropriate amount of training, I think they can easily recognize and treat this condition. And the treatment-wise, I think it's going to be the best way, I think if you ask me, is going to be a layered approach. For example, I think the pediatrician sees the kid and he does his assessments, he gets the history from school, he gets the history from parents, then he makes a diagnosis. And if he feels comfortable, he starts the first line treatment, and then I think he can take things from there. And being a pediatrician, he's going to rule out, I think, all the medical reasons why that would explain this condition. And say, I think we're talking about, if the diagnosis is right, we're talking about very good success rates with first line treatments, right? And I think if the first line treatment is failing, then I think the pediatrician should think, I think maybe I missed something. That's what we all do. Sometimes I think if something is not working, you revisit the whole scenario. In that situation, getting in touch with a psychiatrist colleague would be ideal. And with neurologists, I think, again, if they are trained in seeing children, then they'll also be an ideal resource. But I'm not very familiar with neurology training. I thought it was mainly, I think, adult neurology based, and child neurology is a very sub-specialization, so which may not be available in mandal headquarters.
What you are saying is that a pediatrician with a good enough amount of appropriate training is very well placed to diagnose and start treatment for a child with ADHD if a psychiatrist is not available. If a psychiatrist is available, it is always better to go to him, is what you are saying. And once the pediatrician starts treating a child, and if the child is still not responding, then probably contacting a psychiatric colleague and then working as a team might be a good option, is what you are saying. You are also saying that the pediatrician will also be doubly helpful in the sense that he will rule out any other physical causes before making a diagnosis of ADHD. Okay.
One thing is pediatricians bring a different skill, Raghu. What they bring in is the familiarity with medical conditions that are common in that environment. And what psychiatrists will bring in is looking at a longer angle, looking at the whole picture. So I think with both together, that will make a very ideal combination, really. But if at all we can get in. But if not, then we'll have to go with the model of a pediatrician first, then moving on to a psychiatrist next and take things from there.
And final question, Venkat. This is because I have just recently seen or have heard the history of a 7-year-old child with ADHD who was actually brought to a psychologist initially, and again because of problems with academic level or ability, and then she was diagnosed with ADHD. But there was also a request for EEG. I'm talking about just a pure case of ADHD. Do you think EEG, electroencephalogram, in any way plays a part in ruling in or out any other differential diagnosis or the diagnosis of ADHD? Is it a common practice actually, either in India or UK or USA, to ask for a EEG in case of a suspected case of ADHD?
Let me answer this question in two layers, Raghu. One is, I think, with clinical practice, EEG is not necessary to make a diagnosis of ADHD, unless you're suspecting something, I think, organic going on. Something like, I think, some seizure phenomena, some epilepsy going on somewhere, convulsions, some history is going on, history of brain injury, and you want to rule these things out. That's when I think you commonly require an EEG. But later on, I think as psychiatry is progressing, we are finding more and more biological markers. Name say, I think we are finding few tests that would say, I think, say for example, a patient has schizophrenia, then I think you can find some subtle abnormalities in their CSF, their brain fluid, or you can find some abnormalities, I think, when you're doing a brain scan, those kind of things. Similarly, there is some research coming out which might, in the future, there might be some EEG findings that might be relevant for an ADHD diagnosis. But how useful they would be, it is very premature to predict. And again, I think current EEG practices, the way they are being read, and the way I think the current machines we have, I don't think there is any utility of confirming a diagnosis. But they can help rule out some other conditions when we are in doubt.
So EEG can be an useful tool to rule out other conditions if they are suspected clinically, but not for confirming a diagnosis of ADHD. Very nice. Okay, I think I have used up quite a lot of your time, but I think it has been worth it, Venkat. I myself, being a psychiatrist, did not have this much of clarity before I started this interview, and I say that not to flatter you. Okay, I do think that I have gained quite a bit of a clarity in terms of what is ADHD, what is a presentation, what is the prognosis, or what is the future outcome, and what is the best way to treat ADHD. I hope our viewers who see this video will be able to get that sense as well. And on behalf of all my users and on behalf of MindMattersOnline.com, I would like to say a very big thank you to you, Venkat. Thank you.
Thank you. It's always a pleasure talking to you, and I'm glad you're doing all these things. Yeah, I think keep me posted how it goes.
Thank you very much, Venkat.